There we go. If you'll go ahead and you can flip to the next slide. Thank you. Welcome everybody. We are glad that you came today and we're excited for this webinar. My name is Mark Driscoll. I am the program manager for the PHP program with the Ohio AAP. We have a couple of presenters today, Dr. Amber Healy and Dr. Farrell. I'll go ahead and on the next slide. This is our CME disclosure. Dr. Farrell has no relevant financial relationship with ineligible companies, and Dr. Healy did choose to disclose that she has a relationship with Prevention Bio on their advisory panel. But we have passed this through and made sure that all relevant financial relationships have been mitigated for the purpose of this presentation. And then the next slide. So these are our objectives for today. I'll let you read through those. But hopefully getting to have a good discussion about type 1 and type 2 diabetes today. And then I'll go ahead and read through an introduction of our presenters. So first we have Dr. Ryan Farrell as an associate professor of pediatrics at Case Western University and a pediatric endocrinologist at University Hospitals Rainbow Babies and Children's Hospital. He completed his fellowship in pediatric endocrinology at Case Western in 2016 and now serves as the associate program director for the Peds Endocrine Fellowship at Rainbow. He has clinical interest in the management of youth onset type 2 diabetes and obesity and has served as a co-investigator on several pharmaceutical-initiated research trials and multi-center longitudinal studies of youth onset type 2 diabetes. And our first speaker for today is Dr. Amber Healy. She's an internal medicine specialist in Athens, Ohio with Ohio University. She graduated with honors from Ohio University in 2009. She has more than 11 years of diverse experiences, especially in internal medicine. Dr. Healy has affiliated with many hospitals, including Ohio Health, Holzer Medical Center, Marietta Memorial Hospital, Hocking Valley Community Hospital, and cooperates with many other doctors and specialists in many medical groups, including Ohio Health Corporation. So without further ado, Dr. Amber Healy.
Hi, so I'm going to start us off by talking about type 1 diabetes. So to start framing our conversation, I wanted to give us a brief review of type 1 diabetes. So type 1 diabetes has been estimated to affect about 10% of people with diabetes. The other 90% or so has been estimated to be type 2, although those numbers are probably off a bit due to some atypical forms of diabetes that aren't necessarily accounted for. It is caused by a relative or absolute insulin deficiency, which is caused by a lot of times beta cell destruction. And that beta cell destruction can be a direct destruction from infection, or more of our focus today will be on the autoimmune mediated beta cell destruction, because there's some different testing available now to look for markers tied to that autoimmunity. There are some now genetic components that are more widely known with respect to type 1 diabetes, but we know that most cases are still de novo. Of note, some genetic statistics. One, if your dad has type 1 diabetes, you have a 1 in 17 chance of having type 1 diabetes. If mom had type 1 diabetes, your chances are 1 in 25. And if both parents have type 1 diabetes, we know that it becomes a risk of about 1 in 5 of developing type 1 diabetes. Type 1 can occur at any age. It is more common, however, in children, and the youngest age would be 6 months when an individual would have an intact immune system, because you cannot have an autoimmune condition without an intact immune system. And we do know that as the peak incidences, however, in children occur between the ages of 5 and 9, and then 10 and 14. Next slide, please. So how do we screen for type 1 diabetes? I'm going to jump into this because I talked about the autoimmune component of this. So we start with checking autoantibodies that are tied to different aspects of insulin secretion. Guidelines currently recommend checking for glutamic acid decarboxylase antibody. You may know it better as GAD65, zinc transporter 8 antibody, and then islet cell tyrosine phosphatase autoantibody. My institution calls it IA-2. You might also see it marked as IA-2A, depending on what is available at your specific institution. This is what's recommended by the guidelines to check, but in clinical practice, many people will also check the insulin autoantibody as well. Next slide. So how to screen? We mentioned we check the antibodies, and if you have 2 of those antibodies I mentioned on the previous slide present, then it's a good idea to start screening with an oral glucose tolerance test to look for dysglycemia or the starts of what is like prediabetes for type 1. You also are going to want to look at how much endogenous insulin is still being produced by the individual, and this can be done by checking a C-peptide level. It's been reported that antibodies are present in 80% of children by the age of 3, but I have a patient that's body did not read the book, and I know that this is, pediatricians are the audience today, but I will share that I had a patient in his 50s who showed up to the ER with diabetes, and they treated him as type 2. He came to my office. He looked so much like type 1. I did an antibody screen and C-peptide. His antibodies were negative. C-peptide was in the normal range, and eventually he got to a point where we weaned him off of insulin and he was managed on oral therapy. But then a couple of years later, he presented in the hospital and diabetic ketoacidosis. I rechecked his lab work and he had 2 positive antibodies and his C-peptide had lowered. So this doesn't happen all the time, but they do say that 80% of the time by the age of 3. Next slide. So we look at these antibodies now for staging. So since 2016, it's been adopted that this is something we should be looking at. So when we're looking at staging for type 1 diabetes, if you have a patient who has normal blood sugars and you've screened them with the antibodies and 2 are positive, they are considered to have stage 1 type 1 diabetes that is pre-symptomatic. Their risk of developing type 1 diabetes in 5 years is about 44%. So I mentioned that after you have those positive antibodies, you do an oral glucose tolerance test periodically, probably about once a year, unless symptoms seem to warrant it sooner. And if you see dysglycemia, and this would mean they have impaired glucose tolerance where their blood sugars went somewhere between 140 and 199 during that test, or they have an impaired fasting glucose where the blood sugars are between 101 and 125, then you'd consider them in a pre-diabetes range to have the dysglycemia, and they'd be considered a pre-symptomatic type 1 diabetes, and their risk of developing diabetes type 1 full-blown increases to 75% in the next 5 years. So then stage 3 is where we normally end up diagnosing patients. They meet the criteria for clinical diagnosis: the random blood sugar of over 200, the fasting blood sugar of over 126. The hemoglobin A1C is now above 6.5. They're symptomatic. And then there is progression to stage 4 where, there's this honeymoon phase we're aware of, and you continue to see the decline of beta cell function over that next 6 months to a year in the patient. So they have the full-blown type 1 diabetes. So I go through this because now with being able to screen, there's opportunities to potentially prevent and be aware of some other things. Next slide. So, but when do we screen? This is still somewhat controversial. Multiple studies have shown that screening children who have relatives with type 1 diabetes is appropriate because I mentioned some of those statistics earlier. We know that if you have family members with type 1, you also have a genetic predisposition to type 1. Also, you want to screen individuals who have personal or family history of other autoimmune conditions. Maybe they already have Hashimoto's thyroiditis. Maybe they've got juvenile rheumatoid arthritis or some other condition that's already shown up first. But universal screening is still not widely recommended. There's some people that think that we should be doing it, but in general, it's looking at family history for type 1 or other autoimmune conditions. Next slide. So why do we screen for type 1 diabetes? So one good thing is to help families prepare, because if you know that eventually your child is going to have type 1 diabetes, you're going to be able to learn what symptoms to look for. You can be prepared for what could be coming down the line. And we want to prevent diagnosis occurring in DKA because that does happen a fair amount, and DKA can be deadly. And then lastly, we might want to consider some of the newer medication options that they think might be able to prevent progression to the stage 3 type 1 diabetes that I mentioned earlier. Next slide. So the next question is always, if I'm going to screen for this, what codes do I use to get this covered? So there is some nice patient material that's been provided that I've referenced here that gives some of these diagnostic codes. So if you're trying to diagnose somebody with type 1 diabetes, the E10 codes are nice. If you have somebody that you're looking, if you're just screening for diabetes in general, there's a Z13 code. And you can see some of these family history codes that are also available. So that way you can code it and hopefully get it covered for the patient if you feel that it's necessary for them to be screened for type 1 diabetes. Next slide. And then there's some other resources for patients too, where they can go. TrialNet has been a big proponent for the genetic screening, and this is part of how they found, some of these different markers and genetic risks. Ask Health is another study. Cascade Kids is another study, but that has resources for screening for individuals with families with type 1 diabetes. And then more universally, the JDRF is offering, through their T1 Detect program, an at-home kit where you can pay a certain fee and then have the kit mailed to your home. And then you can screen the child at home and then send the results back and find out if there are antibodies present. And then commercial labs have them available as well. Next slide. So then other prevention considerations, I mentioned we want to prevent diagnosis as hospitalization or as being diagnosed as diabetic ketoacidosis, because it's not a good condition. It's one of those things we've been told for along the years for our training, don't miss this because it can be deadly. Also, there's prevention options available from stage 2 type 1 diabetes. The FDA just over a year ago approved teplizumab, which is a monoclonal antibody that has some modulation effects on CD3, which is tied to the pathogenesis of type 1 diabetes. And so what it's been shown to do is prevent the progression to stage 3 type 1 diabetes. So the trials have shown a median of 2 years of preventing progression in the treatment group compared to the controlled group. So that meant that the control group, basically, it was 24 months to diagnosis compared to 48 months compared to in the treatment group. So that means that there were 2 extra years that the treatment group got not being in full-blown type 1 diabetes compared to the group that did not get therapy. Next slide. So, teplizumab as a medication itself, I mentioned it's a monoclonal antibody. It's indicated for ages 8 and up. And so I mentioned earlier that diagnosis of type 1 can occur at 6 months of age. So if there's a patient with type 1 diabetes who's age 6 months to the age of 7 years, this medication is not indicated for them. It is a 14-day infusion at 30 minutes a day. So there's different strategies people will use to do this: home infusion, infusion centers. So that's what can be sometimes one of the barriers, not to mention the cost. But the common side effects are low white count, a rash, and a headache. And I mentioned cost, just to put this in perspective. This drug is like $193,000 for the series of that 14-day infusion. There are patient assistance programs for it. And the most recent data I saw about use in the state of Ohio, one person at this point has received this medication in the state of Ohio. Next slide. And those are my references. And I will turn it over to Dr. Farrell to talk about type 2 diabetes.
Okay, thanks so much for getting ready to hear me okay. Yeah, so we'll talk now about youth onset type 2 diabetes. And I worry that in talking today that I may actually end up leaving listeners with more questions than with answers. But I think there's just a lot of really helpful information that's kind of come about in these last few years that I think general pediatricians ought to know, and may inform sort of where we go from here in terms of how we screen patients and how we intervene as well. So first off, I think we should speak to the kind of shocking epidemiology of youth onset type 2 diabetes. So just in these last couple of decades, we've seen a doubling in the prevalence of youth onset type 2 diabetes. Though in comparison, it's still a relatively infrequent diagnosis, 0.67 patients per 1,000 cases per 1,000 people. The rates, particularly in the setting of the pandemic, really particularly kind of skyrocketed, and I'll kind of show you that on this ensuing slides. And in particular, it's not a condition that is uniformly affecting individuals, across all groups and kinds. In fact, it's really focusing primarily in this increase in prevalence among patients with a self-identified racial minority background. And again, this is primarily a condition of pubertal and sort of mid-adolescent children, really pre-pubertal children or kids under the age of 10 really have very infrequent prevalence of youth onset type 2 diabetes in comparison to pubertal adolescents. And really in these last few years, we have not seen any changes in the incidence of pre-pubertal youth onset type 2 diabetes. So this is data from the SEARCH study that has shown just sort of the trends in the incidence of type 1 and type 2 diabetes among people under the age of 20. And you can see that there's actually been a little bit of an uptick both in type 1 and type 2 diabetes, but you can certainly see that particularly in these last few years that type 2 diabetes has been increasing at a bit faster of a rate comparatively. So you can see between 2002 and 2015, the overall increase was about 4.8% annualized, with particularly the steepest rates of increase in minority populations. And so on the second graph here, you can see that there's several different subcategories. The overall incidence is the solid blue line, and then subcategories based off of racial demographics. You can see in particular, Black individuals and Hispanic individuals have had significant increases. American Indian and Asian Pacific Islander have also had comparative increases, while white adolescents, in contrast, have had somewhat stable levels over the last several years. And obviously, seeing these rates only through 2015 don't tell the story of the last 5 years and the pandemic. And while this is a different subset of patients, this is from a study out of Kaiser Permanente, so it's distinct and different from the SEARCH study. You can see that this rate of increase, in the years of 2020 and 2021 has really profoundly increased up to, a good solid 60% increase over the last 5 years or so. So it's very concerning data. And this is just a second graph. Again, this is from Kaiser Permanente as well, out of a group of individuals in Southern California. You can see two graphs here, one being these kind of darker circles down the bottom. So those, again, are pre-pubertal individuals, and you can see that those rates over the last 5 years really hadn't changed dramatically. And then in orange, in contrast, the sharp, impressive rate of new cases of youth onset type 2 diabetes in the years of 2020 and 2021. This is again from that same paper, showing again who's in particular had more profound increases over the course of the time of the pandemic, with particular focus to mention that we see that there's been a larger increase, particularly in male patients, which has been somewhat distinct from sort of the historical trends where we found higher rates of youth onset type 2 diabetes in female patients historically. You can see again, as we mentioned before, that the largest increases again have affected primarily non-white children, with particular emphasis on Black children and other racial minority groups as well. So we should talk a little bit about pre-diabetes versus actual youth onset type 2 diabetes, and I think we often think about these conditions as really sort of being in a somewhat of a spectrum, but interestingly, we have found that there's a number of patients that have pre-diabetes that actually never go on to develop youth onset type 2 diabetes. And it starts to raise the question really of, what should we be looking for as we start assessing kids with pre-diabetes, as to how frequently we should be assessing them for progression to youth onset type 2. So again, over the last couple of decades, upwards of 20% of teenagers have been diagnosed with prediabetes. And, over that same time frame, there's actually a surprisingly high rate of remission, where we've seen resolution of prediabetes that have occurred, sometimes in anywhere between 45 and 81% of adolescents over the time frame that patients were studied over a number of different studies. Moreover, when we screen children that are at particularly higher risk for youth onset type 2 diabetes, we actually don't get a big yield out of that. So actually upwards of maybe just 1% or less of patients actually get diagnosed with type 2 diabetes just off of kind of universal asymptomatic screening. Again, we see, obviously, we have a very high rate of obesity across our country with about 20% of adolescents. But again, our cases of youth onset type 2 are comparatively much lower. And in fact, even if you take normal weight, normal BMI adolescents, and you screen them for prediabetes or youth onset type 2 diabetes, you may actually even see upwards of 2% of those individuals that have elevated hemoglobin A1Cs. So again, we have to sort of identify what is it that is truly demonstrating somebody that's going to have a progression into youth onset type 2 diabetes. This is a paper that came out just this year from JAMA that actually did a subcategorization of adolescents based off of their baseline hemoglobin A1C, and then followed them longitudinally over the course of about 5 years. And what we found is that obviously individuals that have hemoglobin A1C levels that are right on the cusp of type 2, so again, A1Cs of maybe 6.3 or 6.4%, have a much higher risk of progressing to youth onset type 2. And in contrast, these kids that have these lower level hemoglobin A1Cs that maybe aren't quite normal, but they're still technically in the range of prediabetes, that doesn't necessarily seem to infer a substantial risk of progression, at least among that 5-year window that patients were followed. So this then begs the question: who do we actually screen, and is there actual benefit to screening all patients, based off of absence of symptoms, just for high risk categories? And there's actually some controversy on this. So in 2022, the USPSTF made a recommendation that at present there is insufficient evidence to support screening of otherwise asymptomatic children and adolescents for youth onset type 2. And in particular, they speak to the fact that there's an absence of data to demonstrate either the benefit or the harm of screening. And again, there have actually been a number of studies that have tried to show, if we diagnose youth onset type 2 diabetes in sort of stages where there's more limited beta cell dysfunction, can we prevent that deterioration, that progression of beta cell dysfunction? And to this point, there really hasn't been a lot of great studies that have demonstrated that. And so in that respect, it begs the question then why spend these healthcare dollars to screen otherwise asymptomatic patients? And again, we still have to ask the question, what we've used primarily for making the diagnosis of type 2 diabetes and prediabetes is really based off of adult reference ranges. And I think there's certainly reason to question if those ranges should be blanketly applied for adolescents as well. So in contrast to the USPSTF, the American Diabetes Association has continued to recommend screening recommendations for patients with youth onset type 2, in particular focusing on overweight or obese children that are, in particular in puberty or at least 10 years of age with any one of the following additional risk factors. So again, a family history of type 2, minority races, as we discussed, having a history of exposure to either maternal or gestational diabetes, and then evidence of insulin resistance, or if there were birth issues, including being small or large for gestational age. So, if those screening tests come back and they're normal, the recommendations have generally been to repeat screenings, typically at a minimum of every 3 years, or sooner if the trajectory of their BMI continues to rise. And there's a lot of variance in practice as to what's sort of the optimal screening test for youth onset type 2 diabetes. There's benefits to things like the hemoglobin A1C in that it doesn't require, a fasting state, so you can grab it sort of randomly. Oral glucose tolerance tests have historically been the gold standard, but, require a lot of effort on parts of families to come in fasting, and it's a 2-hour test. So it's, a lot of effort, to sometimes get those patients in, particularly when they come from, backgrounds that may have more limited means for, coming in for those types of testings. What's the importance of screening for youth onset type 2? So one of the things that we know is that children with youth onset type 2 diabetes, in contrast to adults, really have a more severe and a more aggressive form of type 2 diabetes. So children, as they enter into puberty, have profound levels of insulin resistance. And the thought, I think, is that on the whole, as kids have sort of baseline levels of insulin resistance, that second wave of pubertal insulin resistance is what often will sort of tip these kids over into type 2 diabetes. Moreover, we've seen that children with youth onset type 2 diabetes have much higher rates of beta cell failure, even when we intervene with treatments like metformin or insulin. And they also tend to have much higher rates of diabetes complications. And this has really been something that's been focused on through a longitudinal study called the Treatment Options for Type 2 Diabetes in Adolescents and Youth, or the TODAY study. And I'll show you some data from that on the next slide. So, we obviously know that there's this much more aggressive nature of youth onset type 2 diabetes, but, the thought being that if we can intervene and sort of change that trajectory, can we, are we going to be able to make meaningful outcome differences? And the hard part of this is that to this point, there really hasn't been a lot of prospective evidence that has identified, a capacity to sort of change that trajectory of what we know youth onset type 2 to be. This is again the paper from the TODAY study, from the sort of the final papers that came out. This came out in 2021 and showed the incidence of complications, particularly this really rapid progression of diabetes complications. So just as a bit of a background, the TODAY study was the largest prospective randomized trial that looked at children with youth onset type 2 diabetes and looked at, in particular, the utility of metformin and demonstrated its benefits in kids with type 2 diabetes. And after that study was completed, it continued over the course of about 15 years of follow-up, just to sort of document sort of historical natural history of youth onset type 2. And this is where a lot of this data has been generated that shows, as we see in box B, any microvascular disease, we see upwards of 50% incidence within 10 years of diagnosis. And so that's a really aggressive form of type 2 diabetes. We're seeing such impressive rates of morbidity and even early mortality among patients that were in the study. And I think, this data is what has largely informed, the efforts that we're trying to make now to find when is the right time to intervene and, again, to try to change this outcome. And that, in part, probably also informed this study that was done called the RISE Consortium. And so the RISE study had a pediatric arm that included 90 children between the ages of 10 and 19. These kids were either had a diagnosis of youth onset type 2 diabetes within the last 6 months or have prediabetes. And they were randomized to receive one of two interventions. They either received a year of metformin treatment or 3 months of insulin glargine, like a basal insulin, followed by 9 months of metformin. And then they follow those individuals over the course of this study to assess the markers of beta cell function. And so regrettably, over the course of this treatment, this intervention study, both treatment groups showed significantly lower markers of beta cell function, even a year on treatment, and then at 15 months when they sort of washed out from their treatment. Both groups had continued decline in beta cell function, and that's what is being shown on these graphs here to the right. So what we've learned from this, again, is that youth in this study had significantly lower insulin sensitivity, and their beta cell demand, obviously seems to be much higher, particularly in puberty and in youth. And I think that in part sort of explains this failure of recovery in beta cell function, as was seen in the study. And then moreover, there's been data to this point that even in patients that have what we've historically diagnosed, again, as having normal glucose tolerance. So we think about sort of on an OGTT, on an oral glucose tolerance test, anything under a blood sugar of 140 at 2 hours on a glucose tolerance test, we've always called that normal. But what we found is if you take obese youth and we look at those individuals that have, 2-hour glucoses of 120 to 139 or 100 to 119, if you look at their beta cell function, even at those quote unquote normal levels, they actually are having already evidence of beta cell dysfunction that's happening in these supposedly normal ranges. So it then, again, it begs the question, are these adult reference ranges that we've historically used actually even appropriate for children at all? And moreover, should we be intervening even at these points where these blood sugars are technically normal, but we're already seeing evidence of beta cell dysfunction? So, over the course of these next few years, there's going to be, I think, a lot of efforts from the NIH and the NIDDK to speak to that. And there's actually a consortium that is in the process of being organized that's attempting to identify, based off of risk factors for youth onset type 2, following patients even in these prepubertal years over a longitudinal window to assess risk factors and assess what truly is the right moment to intervene to change the trajectory of youth onset type 2. And that's going to start recruiting this year in 2024. Obviously in these last few years, since the completion of both the two studies we spoke about, the Today study and the RISE study, there are also obviously now this explosion of new effective therapies that now have pediatric indications. So things like empagliflozin, which wasn't studied in either of those studies, is now approved down to the age of 10. And obviously we know that those types of medications, in addition to their effect on A1C, also have really tremendous benefits on microvascular complications. Similarly, glucagon-like peptide-1 receptor agonists, medicines like liraglutide or these weekly formulations now, exenatide and dulaglutide, are also approved down to the age of 10. And we know that, at least from animal data, that there may actually be even some trophic benefits of these medications on beta cell function and beta cell mass. And they may actually be somewhat of a protective factor for those individuals that are at the highest risk for progressing to beta cell failure. Metformin continues to be an initial first-line treatment, and it has very good demonstrable benefits on blood sugars and glycemia. But we also know that about half of individuals, based off of data from the Today study, about half of those individuals treated with metformin will ultimately require insulin within 3 years of diagnosis. So we know that metformin, while it's a wonderful treatment, seems insufficient on its own as well. So, I think, again, these new therapies have also a lot of encouraging impacts on things like cardiovascular function, renal function, like we talked about. These are things that really deserve to be studied in youth as well. And again, as general pediatricians, we have to start asking ourselves, do we wait until, we're in the years of puberty before we start really having meaningful conversations, or do we need to start thinking about this, at much younger years? And I think obviously we all feel very strongly that the sooner we start these discussions, I think the better. Addressing things like sugary drinks and highly processed carbohydrate consumption, the impacts of physical activity and the sedentary lifestyle. Again, I think the data from COVID and the search study and seeing the spikes that we saw in type 2 diabetes during the pandemic probably really did have a tie to physical activity as well. And then, the elephant in the room of things like chronic stress and underlying mental health disorders, I think are truly risk factors as well that we haven't quantified adequately in youth as well. But we know that we need to make these interventions at an early age, and even in patients that have youth onset type 2, if we do get a certain amount of weight loss, even like a 7% drop in weight loss, we see substantial improvements in things like hemoglobin A1C and other metabolic outcomes. And again, when we try to intervene with things like family-based lifestyle intervention programs, I think we all certainly recognize the benefit of treating the family, in addressing things like pediatric obesity. But I think we also see that this is problematic for a number of families that maybe have limited capacity to attend these types of intervention programs. High intensity family-based intervention programs require upwards of 26 hours of direct face-to-face contact between families and providers, and that's a really hard thing to commit to. So it's not surprising that at times families just aren't able to give that time, to address these types of issues. And I think that's also partly what likely informed some of the recommendations by the American Academy of Pediatrics to start thinking more aggressively about using medications like semaglutide and Qsymia, these kind of medications that have come out in these last few years that are approved now down to the age of 12. And so I think, in considering the holistic nature of the patient and the risk of all these comorbidities of type 2 diabetes, I think we all agree that it's worthwhile to start thinking a little bit more aggressively. So between that and in some instances even moving towards things like metabolic bariatric surgery, there's a lot of reason to be optimistic that there's some meaningful ways that we can sort of change the trajectories of what we're seeing with type 2 diabetes. So take-home points for me. To date, there are really no great studies that demonstrate effective therapies that prevent progression from prediabetes in youth to youth onset type 2 diabetes. But there's a lot of new treatment options that are available out there, things like GLP-1 analogs that there's reason to be very positive and optimistic about how they will impact the course of youth onset type 2. On the whole, we know that screening high-risk groups in children is still somewhat low yield, but that doesn't mean that we shouldn't do it, again, particularly if we can tie our hopes to these evolving treatments that are now available in children. Defining prediabetes in youth and youth onset type 2 diabetes based on these adult cutoffs are problematic, and we need to start thinking a little bit differently about what is truly a normal blood sugar in an adolescent child. And then again, puberty in the background of insulin resistance really, I think, seems to be the tipping point. So addressing, the level of insulin resistance prior to puberty really is a must. So with that, I think I'll pause and we can start talking about questions that we've received from the audience. So thank you for your time.
Thank you to Dr. Healy and Dr. Farrell. And we do have a couple of questions in the chat that I'll go through, and then as I'm speaking or we're answering the questions, please feel free to enter other questions that you may have in the chat box, or even unmute and comment or question as well. One question we had from Dr. Lazaron: how much do we need to screen for family MEN syndromes if we're using GLPs more liberally?
That's a great question. Multiple endocrine neoplasia is a very uncommon, pretty rare syndrome that typically will manifest, particularly with MEN2, with a very specific form of thyroid cancer called medullary thyroid cancer. And this actually can be a type of thyroid cancer that can develop in very, very young children. And so typically when we start medications like GLP-1 analogs, we do inquire about if there's any family history of thyroid cancer, particularly medullary thyroid cancer. And oftentimes, if there's a vague history of thyroid cancer, sometimes family members have to kind of clarify with their relatives as to, if they know what their pathology is. And so, it's a question we all ask, but on the whole, I think as long as it's not medullary thyroid cancer, we're generally comfortable to still proceed. There is some data that has shown, again, just very subtle increases in rates of thyroid cancer in people that are on GLP-1 analogs over the course of several years. The relative risk, though, is statistically significant, but it's still small. And so again, I think every initiation of medication comes with a risk balance, risk-benefit balance of assessing is there a risk of developing thyroid cancer later on in life? Perhaps, but it seems to be a very small risk, and contrasting that with the short-term clear benefits of intervening to treating obesity at a young age. So I hope that answers that question.
So, Mark, I also put one question in there too for Amber about, with a lot of times we'll have families that have strong, even not knowing what their autoimmune status is, will have strong family histories of type 1 diabetes. Is there a good handout or a good place to recommend for families or even school nurses or for grandparents with kids who, you're fearful that they might have if they have two diabetic parents, like you were mentioning? Is there a good resource for families for monitoring?
I haven't come across one. I will say, the information I have, I just have a nice patient sheet about like how to get the screening in my office that was provided to me by Prevention Bio. They didn't talk specifically about the symptoms necessarily, but things that do need to be considered, as I'm sure many people here are aware, are excessive thirst, excessive hunger, excessive urination, bedwetting that's out of character for the child, weight loss despite the extra eating, maybe they're more tired, maybe there's been a change in their school performance. Those are all things that we can look for before they start to smell like acetone from going, having that, which is a sign of going into diabetic ketoacidosis.
Ryan, I was really loving your slides, talking a lot on the obesity guideline. One of the questions that we always get, I don't know if you're able to share some of those too, but one of the big questions we always get is like, how much really is type 2 diabetes? Like, how big of an increase is it compared to, bottom line is it really that big of a deal? And, and does obesity really cause any problems? So do you have any particular like sort of wow statements in answer to that, to say like, yeah, it's a problem and this is why we treat obesity, because it causes illness?
Yeah, I think I'll speak to 2 points. One is sort of on a micro level. If you look at individuals that have rapid weight gain over the course of youth and early adolescence, and follow those individuals, you're right. A large number of those individuals will not meaningfully progress into type 2 diabetes. But even independent of type 2 diabetes, obviously there's so many other risks for comorbidities. I mean, there's 200 plus comorbidities that we can associate to obesity and rapid weight gain. And I think on the whole, we really need to think about not just youth onset type 2 diabetes, but sort of even the downstream impacts of that, which to me, I'm really thinking about cardiovascular health. And the fact that even among these individuals that we followed in the Today study, we've already seen individuals in their mid-20s and early 30s that have had myocardial infarctions and strokes. And so to me, to see that level of morbidity at such a young age is so distressing to me. And of course, as pediatricians, we sometimes won't see that because they're already moved on into the adult population. So in one respect, I would say on a micro level, that's very meaningful, I would say. But then thinking sort of on a larger scale, there's increasing evidence that when we have individuals that have rapid weight gain and obesity, particularly as we think about, how that impacts things like our own genetic expression of our genes and epigenetic influences, there's actually now increasing clear evidence that the epigenetic modifications that we see in people that have rapid weight gain are very easily passed on to subsequent generations. So if we're seeing increasing, disparities in terms of, rates of obesity among different populations within our group, that also tends to put people at risk in terms of the echoing of those medical conditions into subsequent generations. And again, I think to me that's an issue of healthcare access and justice that I think we have to address. I think you're still on mute, Dr. Bowling.
One of the other questions I had too, that blip in 20 and 21, I mean, we know about the blip a bit, and I'd love to hear Amber's take on the blip in type 1 diabetes with COVID. Was it COVID related, or was it?
A lot of it was, I think some of it was COVID related. There were studies that looked at both type 1 diabetes and type 2 diabetes diagnosis in some other countries. The type 1 blip is somewhat thought back to the fact that there's actually a COVID-induced diabetes that's been studied because there was evidence that the ACE receptors that the COVID virus utilizes to gain entry into the body were also found on beta cells postmortem in some of the studies. So the thought is that could be a twofold different, cause of type 1 diabetes. So one, it directly damaged beta cells. So it'd be more of the type 1B diabetes where you don't have the positive autoimmunity, but you have the damaged beta cells. And then the other thought was that it was a virus that could also promote a viral inductive phase and promote the autoimmune process, a lot like Coxsackie virus does, because we know that that's like the main culprit one of the main culprits for type 1 diabetes when it comes to an environmental factor that plays into that development of an autoimmune process. So there were a couple of things that they were looking at for that. And then, being at home, like people really did lock down. They were so literal about it. Like they didn't think about, I can still go outside and go for a walk and a hike and stay away from people. Like people literally did not leave their houses. And so there was probably a little bit more sedentary activity in terms of activity. People's diets changed a little bit. I actually tried to do a survey of our population here in Athens about that, and it was mixed, of course, because some people started cooking more at home, some people used DoorDash more, and some people went working from home. They had more access to home food and they weren't taking it the way they were when they worked out of the home. So it's very mixed about the different risk factors that were underlying that. Well, and then I wanted to mention, since we're talking about type 1 and type 2 diabetes, and I was noticing in Dr. Farrell's slides that, age 10 to 19 is the highest rates of type 2 diabetes. And I also mentioned that ages like 5 to 14. So there's an overlap there, right, for type 1 versus type 2 diabetes. And how do we tell the difference? And it is recommended that even if you have a child sitting in front of you and that with type 2 diabetes, you need to screen them for type 1 and make sure that you have not missed the diagnosis, because that can really change and guide how you treat these kids. Because if they need, you don't want to miss a kid with type 1 and have them go on to DKA because you think that they have type 2 and you just put them on metformin or something.
That's a great point, Dr. Healy. So two additional points to that. So one, I didn't speak to this, but there's guidance as to when insulin should be initiated, particularly in people that phenotypically you are strongly suspecting youth onset type 2 diabetes. So for patients that have A1Cs even of 8 or 8.5%, those kids really should also be started at least initially on insulin therapy in addition to any other adjunctive treatments if it's your intention to treat them as type 2. And I agree, certainly, I think for many of these individuals, we really ought to be thinking about doing antibody screening concurrently, you know, as we're treating them. The other point I guess I would make is that there is, you know, among patients that had a diagnosis of youth onset type 2 based off of their C-peptide levels, a percentage of those individuals also actually had positive diabetes antibodies. And so in particular, sort of like a GAD65 antibodies tended to be weakly positive among a subset of individuals that otherwise had a diagnosis of type 2. And interestingly, among those patients, if you follow them longitudinally, they have much higher rates of beta cell failure and eventually insulin requirements as well.
So it sounds a little bit like a latent autoimmune diabetes, like
Yeah.
picture, like the slower decline of the beta cells that we see with that.
Right.
Had another question from Dr. Romano, who said, I've heard Alzheimer's disease being called type 3 diabetes. Do you have any thoughts on that?
I've heard that too. It's the insulin resistance that leads to effects on the brain, but it's kind of hard because you know, there's actually more than just 2 or 3 types of diabetes, you know, probably hundreds at this point. And at one time, the pancreatic or pancreatogenic forms of diabetes, where that somebody has had cystic fibrosis, they've had hemochromatosis, pancreatitis, they've had a Whipple, some sort of damage to the pancreas. It's been called type 3C diabetes. So that gets kind of confusing, but yes, I've heard that. I don't know that it's a completely accurate nomenclature at this point in time, but I'm sure that as we continue to study and look at all these different forms of diabetes over time, that we will be changing names again.
In the one of the recent scientific meetings for the American Diabetes Association, there's actually a lot of discussion about the bidirectional impacts of high blood sugars, hyperglycemia, and executive functioning. And the thought is that there's probably a vicious circle that happens, particularly among some of our youth, where we think about, obviously, patients that have impaired executive functioning may have more difficulties with taking their medications as they need to, and that obviously can raise blood sugars. But then on the other side, high blood sugars actually also seem to directly impact executive functioning. So it's kind of like this vicious circle. And so again, I have to imagine that there could be, you know, actually demonstrable changes that are occurring within the brain that are directly related to hyperglycemia and diabetes.
Any other questions from the group before we close things up?
I just want to thank Amber and Ryan. I was really excited about this talk, and I've gotten a couple of comments, been doing some private messaging, and great presentations, guys. Just really, really interesting.
Thanks for letting us talk. It was fun.
Yeah, thank you.
Outstanding.
I'll just mention a few things that we have from the AAP here. The last of our webinar series for this portion of the PHP program ends with the slide you saw before, which was our anxiety in the tween-age child. So you may have seen that registration when you registered for this webinar because they were all linked to the same form. But if not, and you're interested, you can use that QR code that I'll send out to register for that. Believe the next slide mentions our spring meeting, which is coming up on April 19th. Here you'll hear from the PHP program as well for our ADHD solutions for ADHD and behavior problems. And then we also have Dr. Rupa Thacker coming to speak about making the case for lead testing in your clinic. And then the last slide, I've probably plugged this. Oh, I'm sorry, there's 2 more. So our parenting at mealtime and playtime program also has a webinar coming up on maximizing micronutrients. You can use that QR code there to register for that. And then the last slide that I mentioned a lot, and you've probably got tons of emails from me. We still have copies of our lead prevention resource book that are available for order. So if you're interested in that, please fill out that form to order those free lead resources. Otherwise, I'll echo what Dr. Bowling said. This was a great presentation from Dr. Healy and Dr. Farrell. We thank you for your time today, and I hope everybody has a wonderful Friday and weekend, and we'll see you for the next one. Thank you.